Examination of the ear was already described in a previous class, and this is regarding the examination of nose. I will explain the common symptoms related to nose. The leading questions you should ask while taking history in a nasal case, and also I will explain the steps of nasal examination. But this should be seen only after seeing the video on examination of ear. Otherwise you will lose the continuity, and also I am not repeating the introduction, that is those related to the name, age, occupation, etc. Okay. So in the nose, one of the most common complaint is nasal block. The patient will say that I have nasal obstruction, right? So if the patient is coming with a nasal block, you have to ask for the duration, okay, whether it is acute or chronic. For acute and chronic we have given the criteria of 3 weeks, okay. So below 3 weeks it is acute, and above 3 weeks it is chronic. Then you have to tell the side of nasal block, whether it is right side or left side, unilateral or bilateral. Usually the unilateral nasal blocks are seen associated with a deviated nasal septum or an androgonal polyp or any unilateral nasal masses, and in bilateral usually seen in ethmoid polyp, then allergic rhinitis, or usually septal hematoma. Okay. And whether the nasal block is constant or intermittent, you have to ask whether it is progressive or not. If it is a progressive, then you can think in terms of a mass lesion which is enlarging in size. Okay. So that is about the nasal block. Ask about the duration, the either side of nasal block, and also unilateral, bilateral, constant or intermittent nasal block, and whether it is progressive or not. Next common nasal complaint is nasal discharge. Patient will say, I am having discharge from my nose. If so, you have to ask whether it is unilateral or bilateral. It is coming from right side or left side, or from both sides. Then type of discharge, and also amount, whether it is scanty. Patient will say sometimes it's coming very little, or sometimes the patient says it is coming in copious amount. So that also you have to ask, and you have to write in history. That is, this comes under the presenting complaint, and all this comes under history of presenting complaint. The order you have to follow is described along with the examination of ear. I am not repeating. And regarding the type of discharge, ask, these are the common type of nasal discharges. And watery, water-like, it is flowing like water, very thin water. What is, tell me a condition which causes, common condition which causes watery nasal discharge. It is common cold, allergic rhinitis, vasomotor rhinitis is again a common cause, and also CSF rhinorrhea, you get a watery nasal discharge. And mucoid, what is this mucoid discharge? Mucoid, I already told in ear examination, it is like sticky in nature, mucoid, because of the mucus secretion, it is sticky. So that type of discharge you get in, especially in cases of allergic rhinitis, and in allergic fungal rhinosinusitis you get greenish mucoid discharge. Purulent type is commonly seen in case of foreign body nose, then in pharyngosis, of the nose, then sinusitis. Any infective pathology you get a purulent or a mucopurulent, and blood stained, no doubt you will get in malignancy. Again nasal myiasis. Okay, nasal myiasis you get okay, this again is very important topic. Myiasis, you get a blood stain discharge. And also in case of malignancy nose, again it is blood stained. The third one is facial pain or headache. All these you have to ask. That is, first thing, how your pain started. Whether it was spontaneous or it was induced by something like trauma. Second, how long the pain lasts. Ask the patient, it is for minutes or hours or the whole day. Okay. Third is aggravating or relieving factors. And also like what? Aggravating and relieving factors like stooping forward, looking continuously over to a something, or while reading, like that. Then associated symptoms. What is that for? Mainly these associated symptoms you ask in case of migraine. Okay, like the history of aura, like any visual problems, or nausea, vomiting, like that you have to ask. And also if there is no associated symptoms or no aggravating or relieving factors, that you have to write in your history of present incomplete. Okay. Then whether there is any diurnal variation. What is that? If the is there any change in the intensity of the pain at different period or the different time of the same day, or day and night variation. That is diurnal variation. What is the importance of that? Usually this diurnal variation occurs for sinusitis. There are typical presentation for each sinus headache. Looking at the history only, you can find out the sinus affected to a great extent. The pain of frontal sinusitis will be more felt on the eyebrow or on the superciliary area, and it will be aggravated when the patient looks down. And the patient give you a typical history that the pain was more when the patient get out of the bed. It lasts for a few hours and it decreases towards the evening, and that is called office headache. Okay, office headache is seen in case of frontal sinusitis. Why? Because the frontal sinus has got a gravity dependent drainage. So the pus or the collection will be more in the morning hours, and towards the evening, because the drainage is gravity dependent, it gets relieved. Okay. And in case of maxillary sinusitis, the pain will be felt also on the upper teeth and also over the cheek, and it will be more towards the evening. Okay, the patient will be comparatively free of pain when he wakes up from bed, and it will be aggravated towards the evening. And the ethmoid sinus, the pain of ethmoid sinusitis is more felt in the complained by children, and it is usually behind the eye, and also it will be aggravated by eye movements. And the sphenoid sinusitis is more common towards the vertex or in the occipital area, and it will be aggravated by, again it will be aggravated by the movement of eye, and also it will be associated with the visual disturbances. Okay. So that is regarding the diurnal variation. And also ask for a painful or restricted neck movement, because sometimes the pain may be due to a cervical spondylitis or any cervical problem. So that is the importance of asking this. So in pain, if the patient is complaining of pain, ask all these. Common complaint is epistaxis, that is bleeding from the nose. If so, ask about the amount of blood loss. Then if there any trauma which caused the epistaxis, and also ask for intake of any drugs like warfarin or anticoagulants, and also the bleeding from other sides and similar episodes in the past. Okay, that is also important, especially in case of rhinosporidiosis or juvenile nasopharyngeal angiofibroma. There will be recurrent or malignancy. The patient will complain, tell you the recurrent attacks. So that is important. Then again, the next one can be disturbance of smell. If the patient tells about any disturbance in that, you should ask about all these. What is this? What is the difference between all this? This anosmia is total loss of smell. Okay, it is total loss of smell. In which all condition you get a total loss of smell? In case of head injury or intracranial space occupying lesions, or it can be functional. Okay, total loss of smell. Then hyposmia is reduced sense of smell that you will get in any mass lesions like ethmoid polyp or an androcorneal polyp, or even in allergic rhinitis you get an hyposmia, hypo, reduced sense of smell. And what about this parosmia? Parosmia is an altered sense of smell. Okay. Patient has the perception, but it is altered, right? Again, parosmia is commonly seen in allergic rhinitis. And cacoxmia, what is that? Any smell perceived as foul. That is cacoxmia. You get it in a sinusitis, especially in case of allergic fungal rhinosinusitis. The other one is postnasal drip. The patient will tell you that I am having a feeling of excessive discharge coming to my mouth. And on examination you will see whitish waterfall like discharge seen on the posterior wall of oropharynx. That is the typical presentation of a postnasal drip. It is seen more commonly in case of allergic and also in infective conditions of chronic sinusitis or any mass causing obstruction to the nose, in which case the discharge will be more. Okay. And another one is change in voice. And the next complaint, the seventh complaint is change in voice. Actually, the nose and paranasal sinus will give the timbre or the quality to the voice. If there is any nasal block, there will be a nasal twang to the voice. And if there is mass filling the nasopharynx, you will get the typical rhinolalia closa or the closed voice. And in case of cleft lip or post-adenoidectomy patient, you will get the rhinolalia aperta or the open voice. Okay, that is important. And another common complaint is sneezing, right? That is any allergy, nasal allergy will cause this sneezing experience. So all these should be asked in history taking, right? And if the patient give any of these complaints, you should ask the leading questions which I have already mentioned. After history taking comes the clinical examination. In ENT, the system of lighting is different. The use of bullseye lamp and the mirror I explained with the examination of ear. I am not repeating it here. Now I am directly going to the examination of nose. I will tell you the steps, and then after that I will show the examination in a real patient. So the first one is face and orbit, and after that comes the external nasal framework. Then cold spatula test. Thing is, in some books it is given as functional examination separate from clinical examination. So the ideal thing is that before touching the patient nose, you have to check for the function. The cold spatula should be done before you touch the patient face. So the order is like this only. So after looking for the external nasal framework, do the cold spatula test. Then comes the vestibule and columella. Then the anterior rhinoscopy. Then paranasal sinus tenderness. Next is postnasal examination. Postnasal examination I described along with the examination of nasopharynx. And the last thing is examination of nasopharynx. That is, after doing the postnasal examination, you have to palpate the nasopharynx. That you don't do it in every patient. If the examiner tell you to examine or palpate the nasopharynx, then only go for that. Otherwise, in clinical practice, the diagnostic nasal endoscopy will be enough for that. There is no need, because it is a little bit discomfort to the patient. So how will you palpate the nasopharynx? You allow the patient to sit in a chair and the examiner stands behind the patient. If the patient is sitting here, examiner stands behind the patient, and for a right-handed examiner, using the index finger of left finger, invaginate the cheek of the patient. That is to avoid accidental biting of your index finger. And invaginate the cheek with the left index finger, and with the right index finger go behind the uvula and examine the various parts in order as you saw in a postnasal mirror. Okay, that is from midline. Either you can go from the midline from the posterior end of septum, roof and lateral wall and the floor, or in the other way. So you can start from the lateral wall and then roof, the posterior end of septum and the floor. And while taking out, look at the tip of your fingers. Sometimes bleeding will be seen. in case of an early nasopharyngeal carcinoma or any bleeding lesions, especially in the fossa of Rosenwalder. That is important. That is for the right-handed examiner, and for left-handers you can make your own alterations, right? So in history taking, there are 8 common complaints, and also for clinical examination there are 8 things you have to examine. And now you see the method of examination of nose. Examination of the nose starts with the examination of face and orbit. Look for facial asymmetry, telecanthus, facial swellings, epiphora, proptosis, etc. Examine the eyeball movements in all directions. Palpate margins, orbital margins, especially the infraorbital margin. Look for any asymmetry or stepping, especially in case of trauma. And you have to check the visual acuity. If the Snellen's eye chart is not available, grossly test it. And this is how the proptosis has to be checked. Examiner should stand behind the patient and look from above for any bulge or asymmetry of the orbit. After that comes the external nasal framework. Examine both the skin and also the osteocartilaginous framework of nose. After this comes the cold spatula test. Ideally, you have to do this test before even touching the nose of the patient. Keep a cold metallic tongue depressor just in front of the nostril and ask the patient to breathe normally with the mouth closed. During expiration, you can see, look for area of condensation on the surface of the tongue depressor. See, and this fogging is compared and it will be reduced on the side of nasal block. Next is examination of vestibule and columella. This is columella which separates the 2 vestibules, and vestibule is the anterior skin-lined area of the nasal cavity. And after this comes the anterior rhinoscopy examination. You can use the Todicum speculum, and this is the Plichus, or there is also St. Clair Thompson's nasal speculum, or there are Killian's nasal speculum. And the smaller one is Todicum. And you should know how to hold the Todicum speculum. It's usually asked in examination. This is how you hold the Todicum speculum. And in all cases, the speculum should be closed before entering into the nasal cavity. See, I'm going to do the anterior rhinoscopy. Note the method of holding the Todicum speculum. Close the speculum and introduce it into the nasal cavity and examine you can see the nasal septum, anterior part of nasal septum. Then in the lateral wall you can see the inferior turbinate, inferior meatus, middle turbinate and the middle meatus, and also the floor. And if there is mass present inside the nose, you have to go do a probing. Probing is touching the mass with a probe, that is a cotton tipped applicator, as we palpate the abdominal mass with fingers. And uses of probing are to find out consistency of the mass, sensitivity, whether it is sensitive to touch or not. Like an inverted papilloma is usually sensitive, and bleeding to touch, tenderness or not, shape or mass lesion, number, site of attachment, and cuff impulse. And while examining with the Plichus or St. Clair Thompson speculum, you have to hold the ala of nose with the index fingers. Okay, and you have to examine on both sides also, right? And after that comes the Cortels test, that is retracting the cheek laterally. And if there is a block in the nasal valve area, on doing the test, that is retracting the cheek laterally, the patient will feel better. Next comes the paranasal sinus tenderness elicitation. For the frontal sinus, you have to palpate at the floor of frontal sinus. This is the area below the lower border of eyebrow, which corresponds to the floor of frontal sinus. Always palpate, never palpate on both sides simultaneously, palpate each area separately. And this is for the ethmoid, that is between the root of nose and the medial canthus of eye, right? And give a pressure, the too much pressure, you should never give it too much of pressure, that will cause pain, and also too little pressure will cause erroneous result. And this is for the maxillary sinus tenderness. You have to palpate at the canine fossa. I have explained canine fossa, boundaries of canine fossa is important. It was already explained along with the osteology of maxilla class. And this is the corresponds to the anterior border of the maxilla.